This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on the social media and use the hashtag #AssemblyHealth for this meeting. Please may I remind participants to silence your devices. The main item on the agenda today is a question and answer session with the GLA Health team. However, we have a few short items of business first. So can I please ask Diane Richards, our committee clerk, to confirm if there are any apologies for today's meeting.
Thank you, Chair. No apologies for absence have been received for today's meeting.
Great, thank you. Can we note the list of offices held by the Assembly members? Can I also ask members if they have any disclosable interests in any specific items listed on today's agenda? And I take silence as meaning no. Can we confirm the minutes of the meeting held on the 1st of February 2024? Agreed. Can we note the completed, closed and outstanding actions arising from previous meetings? Can we note the action taken by me as Chair under delegated authority in consultation with party group lead members, namely to agree the committee's report on eating disorders?
Noted.
Can we note the response from the Mayor of London to the committee's letter on trauma-informed approaches to youth violence?
Noted.
Okay, thank you. That brings us to today's main item. I'd like to extend a warm welcome to our panel members and the guests from the health team for our answer question session. I'm going to leave it to each of you guests to introduce themselves rather than me trying to attempt. So let's start with you, Emma, and then we work down across the committee. Thank you.
Thank you. I'm Emma Pawson. I'm Head of Health, but I'm also lead for Universal Free School Meals.
Hi, I'm Jazz Bhogal. I'm the Assistant Director for Health, Children and Young Londoners at the GLA.
I'm Tom Coffey, and I'm one of the Mayor's Health Advisors.
Good afternoon. I'm Kevin Fenton. I am the Regional Director of Public Health for London with the Department of Health and Social Care and NHS London. I'm also the Statutory Health Advisor to the Mayor of London.
Good afternoon. My name is Vicky Hobart. I am the GLA Group Director of Public Health and Deputy Statutory Health Advisor to the GLA.
Thank you. Welcome to all of you, and thank you very much for coming to share your thoughts with the committee. I know that Dr. Tom Coffey and Professor Fenton want to make introductory remarks for 5 minutes each, I think. Which one of you, Dr. Coffey, wants to go first? Great.
First of all, thank you for inviting us today to allow us to kind of work together to review the work we've done over the last 3 years. And I'd like to say a big thank you to Dr. Sahota, who I know is standing down from the Health Committee and from the Assembly in the next few months, to thank him for the work he's done to improve the health of Londoners, but also the work he's done to serve his community in Ealing, where he represents. So a big thank you from us for the work you've done over the last few years. Also, I'd like to say that we're very much here as a team, and none of us have the expertise all held in one person. Therefore, when we answer today, we'll try to do it as a team. So I know you might direct a question to one of us, and that person will honour that request and give you certain remarks, but they might want to bring in colleagues, just so you get the benefit of the collective wisdom. Also, our job here is also to listen to you. You've now developed over the years a similar degree of expertise in your fields, and I'm sure you'll be making recommendations to us and suggestions how we might want to work going forward and reflecting what we've done in the past. So in the spirit of cooperation, I want to take those recommendations you give to us as a way for us to learn from yourselves, because you've done some excellent reports over the last few years and many recommendations, many which we've tried to implement, so we do want to work in that collaborative fashion. What I want to do is just 2 things at the beginning. First of all, just to describe to you the approach that we've tried to use to improve the health of Londoners and addressing health inequalities. The first thing is we've used very much our Health Inequalities Strategy. Now, Kevin's going to talk about that in more detail, but that's been almost our guiding light to try to identify where the greatest needs are and what we can do to make sure we're addressing the needs of Londoners. Secondly, we've got certain programmes of work. And what Sadiq said to us right at the beginning, he says, Tom, this is a 3-year term. Don't start inventing new vehicles to deliver health improvements. Work with what you've got already. And the 3 or 4 things that we've very much used over the last few years is our Healthy Early Years, Healthy Schools programme, our Thrive London, our work with the NHS to make sure we're using existing vehicles to deliver change and not creating new infrastructures. Thirdly, we very much feel we need a partnership approach. The Mayor does not commission healthcare, but he works on behalf of Londoners to improve the health of London. So our key partners are the Health Service, local authorities, Directors of Public Health, business community, voluntary sector. And often the London Health Board encapsulates that partnership working. And we're trying to make sure that partnership we use to improve Londoners' health. And fourthly, the health in all policies approach. This is something we've developed over the last few years, which I know we'll go into some more detail later. But Sadiq recognising, and I recognise, that what I do as a GP probably has a minimal impact on people's health outcomes. What's just as important is their transport system, their employment, their housing, their childcare. All those things we need to improve the health outcomes of Londoners. And Sadiq uses the Health and All Policies approach to try to lever that from his departments of transport, from housing, from planning, etc. Now, the second thing I wanted to talk about, apart that's our approach, is what are some of the achievements that I'm particularly proud of that I wanted to share with you, which, hopefully they're ones which you also feel have progressed and improved the lot for Londoners. We've developed dementia-friendly cultural venues. We've now got over 100 in London to make sure that patients, Londoners with dementia, aren't losing out on the opportunity to benefit from what London has to offer. Sadiq himself is a dementia friend, and we've got many dementia friends in the City Hall, and we've got our own dementia champion. Secondly, a great achievement I'm quite pleased about is our school super zones. We had an ambition of 50. Could we get 50 in some of the most deprived areas of London in that 3-year period? We've in fact exceeded that and got 85. 85 areas now benefiting from that programme of improving the vicinity around those schools to improve the health of those children and families. Thirdly, water-only schools. I remember when I saw the initial work on water-only schools, and I thought, is this just about childhood obesity? But the studies in America showed not only does it improve children's weight, but it also improves their educational performances and behaviour at schools. So we've now got 478 water-only schools in London. We only had a handful 3 years ago. Healthy early years. This is something which started in Sadiq's first term, and it's continued in the second term. And now we've got over 2,000 healthy early years settings in London. That also gives us a building blocks to improve the health of those children. So we've got now a framework. We can do new initiatives, new work, things that you might suggest today that might be considered potentially in the future. Mental health champions. So we've now got in London almost our target of 250,000 by 2025. We've now got 220,000 mental health champions in London. Mental health being one of the key pivotal areas that Sadiq wanted to focus on in this term, and this policy initiative being one of the ways he wished to deliver it. Zero suicide training. A lot of us have been touched by suicide and recognise the tragedy it is, not just to the immediate family, but on average to 130 other people affected by one suicide. We've now managed to get 380,000 Londoners on a zero suicide training course. Air pollution. We know that air pollution brings premature death to 4,000 Londoners a year. We also know now that it has an effect on the causation of dementia, of lung health, lung disease. And we've had now a 21% reduction in nitrous oxide in central London over the last 3 or 4 years. So they're just some of the achievements that I'm very proud of, hopefully across the wider gamut of the work that Sadiq does, to show that we are very much focused, wherever we can, on outcomes. We don't succeed in everything we do, and you've got to admit that and learn from your failures, but also I wish to share with you what I believe are our successes. Thank you. Thank you.
Thank you very much, Chair, and good afternoon again, colleagues. Dr. Coffey has set out a compelling narrative for the work that we've accomplished and the priorities of the Health Inequalities Strategy. A reminder that the strategy was developed in 2018, and at that time it followed a period of intense partnership working and community consultation. Published alongside the strategy in 2018 was an implementation plan to 2020 and a set of population health indicators. challenges. And over the past few years, and certainly since I've been here as the Regional Public Health Director, we've committed to publishing progress reports, the last being published in 2022. We currently have an implementation plan which goes between 2021 and 2024, and that implementation plan was published in December of 2021. So we have been active in both the development of the strategy, articulation of population health indicators, and ensuring that we have implementation plans reflecting on our progress with the strategy. To start us out this afternoon, though, I thought I'd begin with setting the scene, looking at the data for the region, recognizing that we are operating within a framework of multiple concurrent challenges across the city at a time when we are emerging from the COVID-19 pandemic with a significant widening of health inequalities, a significant impact on life expectancy and healthy life expectancy, and real challenges experienced by Londoners as we've gone through the acute phase of the pandemic, through the cost of living crisis, and are now faced with a range of threats. In this first slide, I wanted to reflect on life expectancy at birth in the city. And you can see that following the COVID-19 pandemic, we saw a dip in the life expectancy for both men and women. And although life expectancy in London is higher than the rest of the country, you can see we experienced the same dip that the rest of the country did. Now, although we're beginning to see some positive signals of a return and increase in life expectancy across the city, it is nowhere near what it was prior to the pandemic. And we now understand the factors which are driving these changes in life expectancy, and I'll be discussing them in a bit more detail further on. In the next slide, I'd like to reflect on healthy life expectancy, which is the time, how long people are living in good health as they see it. And again, for both men and women, we tend to have higher healthy life expectancy in London than we do outside of London in the rest of the country. But we've also seen a fair stagnation of healthy life expectancy for men and women as we've gone through the COVID-19 pandemic. What we now know about healthy life expectancy is that there's significant variation across the region. For example, in the baseline the gap between the highest and the lowest London boroughs were significant for both men and women. And we know that healthy life expectancy for men, for example, is 58.1 years in Barking and Dagenham and up to 70.2 years in Richmond upon Thames. We see similar disparities for women as well, with healthy life expectancy being 57.8 years in Tower Hamlets and 70.1 years in Wandsworth. Now, the factors which are driving the changes that we see in healthy life expectancy and life expectancy are many. Clearly, we have the long-standing impact of our experiences of going through the COVID-19 pandemic. We have a rising tide of non-communicable diseases, which are driving both pressures on the NHS and increased number of Londoners who may not yet have their chronic conditions diagnosed or effectively managed. But we also know that we're seeing significant demographic shifts and trends across the city as well. One of the conditions we are particularly concerned about is cardiovascular disease. And in the next slide, what I wanted to highlight, next slide, please. Thank you. The differences that we're seeing in levels of control of cardiovascular disease and blood pressure control across the city, and how that varies depending on where you are in the city. So in areas of greater deprivation on the left-hand side of that chart, you see that the proportion of individuals with blood pressure who are maintaining good control are significantly lower than areas which are more affluent to the right-hand side of the chart, where you see higher levels of blood pressure control. Now, heart disease is particularly significant in the city, in part because it is a major driver of health inequalities. We see significant differences in the prevalence of heart disease by gender, by race, ethnicity, and of course, by deprivation. Now, in the next slide, we know that not only are the threats that we're seeing coming from chronic diseases, but also infectious diseases as well. And I've highlighted here trends in or late diagnoses for HIV infection, where you see significant differences across racial and ethnic groups, despite the fact that we're continuing to see reductions in HIV incidence in the city. So in other words, although we're making progress with reducing HIV new diagnoses, we're seeing an increasing proportion of individuals being diagnosed late, especially among our Black, African, and Black and ethnic minority groups compared to white groups in the city. In the next slide, I wanted to end by just reflecting on the key elements which are going to be critical for success. I often refer to these as the keys to success for efforts to tackle and understand and respond to health inequalities in the city. And it requires a number of key things to be present. First, strong, visible leadership for health inequalities, provided in London by the Mayor, provided in London by health and care leaders who are working together on health inequalities, provided by local authorities and community leaders across the city. Second, we need to have strong governance. And in this slide, we show London's strategic landscape, where we see the intersections between the major pan-regional strategies interfacing with governance structures within the NHS regions, ICSs, local governments, and the ways in which we're working to align all of the structures within the city to focus on health inequalities. Third, it requires not only the infrastructure but good governance and accountability across the city, and the Health Inequalities Strategy has provided that oversight, the metrics to measure our progress, but also to ensure that we're holding different partners to account for progress on the Health Inequalities Strategy. Fourth, we require great data. And there's been a lot of work done over the past 4 years to strengthen the data on which the inequality strategy sits, to measure our progress, to identify areas which are gaps, and to ensure that we're agile in our responses on health inequalities. So as the data changes, we're able to adapt our strategic responses. Finally, as we've heard from Dr. Coffey, our partnerships are critical, and all of the accomplishments that we're going to be discussing today reflect the deep and enduring partnerships that we've developed around the Health Inequalities Strategy, which are key for success and are valued and are supported and will be key to our work moving forward. So, colleagues, with that, I wanted to give you a sense of our journey with the Health Inequality Strategy, the data which underpin the decisions that we've made and where we've focused over the past few years, the London strategic infrastructure, and the keys to success for tackling health inequalities in the city. Thank you, Chair.
Thank you, Professor Fenton. Thank you for setting the landscape up and telling us the journey which we've been over the last few years. My colleague, Assemblymember Russell, wants to come in for a moment.
Yes, Chair. I just wanted to pick up on some of Dr. Coffey's words at the very outset of the meeting, thanking you for your work as chair of this committee and also your very long service on this committee, because I understand that you've been an Assembly member for 12 years, and of those 12 years, 9 years, you have been chair of this committee, which is a huge commitment to the health, to the reducing of health inequalities of Londoners. And for that, we're all very, very grateful. And I think in particular, bringing your voice as a practicing GP has also given the membership of this committee just that extra bit of breadth of perspective. So I just want to, on behalf of all the committee, I just want to thank you for your service to this committee and to the health of Londoners. Thank you, Anka.
I'm humbled. Thank you very much. And I think
Likewise, I'd like to echo those sentiments. I mean, I was only chair for 1 year, but the guidance that you gave during that year, and I've known I've known you, Anka, for many years beforehand. But your work, particularly around the NHS, we had sort of the campaign. I know when you were first elected around A&E services. And that really brought into light the issues, and I think that's made a big difference to even the Mayor's strategy today about the 6 key tests and all the work that is happening here at City Hall on that front as well. So, very proud to have served alongside you as well.
Thank you. I was just reflecting, sitting on the journey on the Health Inequalities Strategy, which started when Professor Darcy was the commission of the Darcy Commission, right? He set up the thing, and the Mayor of London was Mayor Johnson, so it's not just journey when we started looking at the health strategy for the first time. So thank you very much for your comments, and I'm really glad that we saved Ealing Hospital and Charing Cross Hospital. If we had lost those 1,000 beds in the middle of the COVID pandemic, we would have been in a worse place than we were already. So thank you very much for your comment, and I'll probably say a few more remarks at full assembly on Friday. But I think for this afternoon we better carry on with the agenda. And I know particularly that Professor Fenton wants to leave at 4 o'clock, and my colleague Krupesh Rani wants to leave 4 o'clock also. So let's go on with the agenda. And thank you very much for your kind comments. I'm going to start off the questioning for this afternoon, and I'll direct my questions to you, Dr. Coffey, as you started to talk about super zones earlier on, and I think you've told us that we had ambition to have 50 super zones, but you've now got 87. What was 87? I think was the figure. 86, sorry. Okay.
86.
Yeah, right. 86. Right. Okay. So, I mean, what the mayor has changed the criteria for the super zones, so that it's easier for an area to be designated as super school zone. Was this a decision which was taken purposely, or what was the driver behind that decision?
So thank you, and also thank you for the support. As we developed the super zones policy, we did get feedback from colleagues earlier in the inception of the programme. So I'm going to probably also invite Jazz to come in at some point, because she's got the area of expertise and carries that brief for school super zones. The key thing for us very much was to make sure that there were 7 or 8 areas which a school super zone could look at to say which of these areas I think are important to us. Secondly, we were very much seed funding, grant funding areas to support the work which started the programme. It was up to the school and the adjoining schools to collaborate on that area. So as we went through the programme, the programme changed according to what was important to both us and to the schools accordingly. I'm going to just hand over to Jazz now, just to go into some more detail about how we gradually developed the programme, and in fact how we might be developing even further in the future. Thank you, Jess.
Thank you, Tom, and thank you for your question. The Super Zones programme, I think, you'll be aware, that was initially devised based on a pilot programme that focused on schools, albeit in partnership with the boroughs that those schools are based in. And as we began to roll out the full phase beyond pilot, and we began to roll this out more broadly, the focus being still very focused on those schools in the neighbourhoods that suffer the greatest deprivation. Working with boroughs, they were really keen. They got much more interest from some of their schools in those neighbouring areas to be able to take part in a scheme. And actually, we worked out that it would be possible and actually very advantageous to have groups of schools taking part in a super zone. So actually, whilst we actually kind of rolled out, the zones then became different in terms of their geography, their span of influence, and actually were able to have much better and greater collective impact in those local areas. For example, a super zone priority might have been around really kind of changing and affecting the retail options for children so that there was healthier food and options available to them. Actually, for those retailers, the benefit was much greater to have a larger number of schools that were involved in that, and the economy of scale began to work better. Actually, what we found was that didn't take away from the methodology and the evidence base that we created around that. So actually, we just thought this is a much better opportunity. So the scale was actually of interest to schools who were very keen to broaden this out, and those neighbourhoods, the geography that we'd previously sort of discussed was actually, the option there was to make that much broader. It's ended up being a bit of a win-win, and certainly the evaluation that we've the earlier findings from the evaluation that we're now looking at are suggesting there's been a significant benefit to those local areas, and that's something that they want to continue.
And just to give you a flavour of something, so what does it achieve? And just from a sample of 15, I asked people, well, you know, and some of the examples were, so therefore, new businesses signing up to the healthy catering commitment around the school, 3 road improvement projects, 4 new school streets, improved lighting and CCTV around the schools, 2 school super zones had smoke-free zones. So there are real concrete improvements to the infrastructure around those schools, benefiting the children and families. So the evaluation which we've done, and I think we've always been pushed, are you evaluating your work, Tom? Are you making sure that this is money well spent? We do, and we adjust our programs according to our evaluation. So there's some of the concrete benefits, literally, that have been achieved by that program.
So no, it's not yet. It's in its final stages. We're working really closely with our evaluators so that we're getting as early as possible insight and feedback, and so that's beginning to help us think about the future. And some of the options for us to think about is, we know that there's opportunities to think about secondary schools. Mm-hmm. So far, super zones were designed and focused around primary schools. However, some of those primary schools are attached to or part of a through school model. So there are some areas, I went to visit one in Thamesmead in South London, and that's a through school from reception all the way through to sixth form, and that's a really interesting model. So actually what they're finding, some of their older children, not only are they being able to take part in the super zone and have a bit more of a role in looking about the area around their school, they're feeling ownership over that programme and actually making some quite practical suggestions themselves. But actually the kind of the engagement with that wider community, and the community feeling that that neighbourhood around that school feeling like it's part of a super zone. So actually it's the beginnings. It feels like kind of the options that there is potential to look at what that local area can do to own that super zone model for themselves, and that's beginning to look really exciting. The other area I think there's the evaluation is suggesting we might be able to think more about is putting more things around well-being and thinking about mental health and well-being within those models.
Great. Thank you. And it would be very, very helpful if you could share those evaluations with the committee when it comes forward.
When it's available.
And you talked about about well-being champions. What do they mean? What's their definition?
I'll remember eventually. So we initially started off with calling these Londoners mental wellbeing ambassadors, but we realised really that was perhaps not the appropriate terminology. So we used the word mental health champions. And these are Londoners who have taken courses and done projects which are accredited and give them a degree of mental health expertise. The examples I would give, they might have done the zero suicide course, they might have done mental health first aid training. So areas like that, so that they then are enabled to be working within their communities, offering a bit of community expertise, because often when a person is in mental health distress, they will often turn to a friend, a neighbour, a family member. They don't always come to me or you, Anka, as GPs. What's really important is that person has the confidence to say, how do I deal with this crisis? where do I take this person to? Can I address this person with a simple conversation, or do I need to escalate? And that's what, wherever possible, our mental health wellbeing champions, do. I'm going to just pass over to Emma, who has worked on that project, to make sure that we support the mental health champions as well as put them on courses. Emma.
Thanks, Tom. And as Tom was saying, we try to make it as inclusive as possible. So we've moved into a very broad spectrum of support that we can offer to Londoners in response to different phases as we've gone through. So, for example, during COVID and as we came out during the recovery phase, there was a much greater need for bereavement support. So we channeled our energy into how we could support communities through that bereavement phase. In other things, we're starting to see in the data an increasing number of young people with mental health issues, and therefore, as our programme has evolved, we've started to look at how we can train and skill up people who are in touch with young people to better raise awareness about what mental health looks like and what support is out there, and the small things that they can do just to be open. It may even be just opening conversation, right the way through to encouraging people to do suicide training. So far, I'll give you a few examples of what we've done. We've trained over 4,000 people in young people in education settings, and of those, over 100 people are skilled and trained to be able to train other people. So we're really cascading beyond the reach that we can have. Another example is that we've done, as Tom mentioned earlier, the suicide awareness raising training. We've had over 380,000 people take that, and that enables and skills people up to be more confident to be able to support anyone that they think may be struggling at the moment as well. So that's just two examples. There's lots more that we can give and offer afterwards if helpful.
Great, thank you. Now I'm just going to talk a bit about air quality. Tom, or Kevin, is London on track to meet the World Health Organization's interim target for PM 2.5 particles by 2025? So by 2030, are we on target to meet that World Health Organization target?
So we have done a lot on air quality. To be honest, I don't have that level of detail at my fingertips at the moment regarding the trajectory we're on at the moment, and are we likely to hit the target by 2030? What obviously I can share with you, and and Kevin hopefully will give the inequalities angle as well. But what I can share with you is the impact we've already had about the reduction in nitrous oxide, PM 2.5. And PM10 particle pollution in London. What we can share with you is that what we do know is that the areas of London with the poorest air quality are where the poorest Londoners live. And therefore what we're trying to make sure we address is reducing that air quality, particularly in those areas. And what we are aware of that London's air quality is improving faster than the rest of the country. And that as we're doing more and more initiatives to make our city greener and lower air pollution, we are moving towards that target in 2030. Can I give you the exact graph? I don't have that information. I think that might be held in the environment team, but I will get you that information because I think it's vital to know, are we going to hit that target? But what I do know is the amazing progress we've made, over the last few years, and we continue to make, because we know this has got a direct impact on Londoners' lives. So many surveys have shown, in fact, that by investing in reducing air pollution, you're benefiting the health service to the tune of millions and billions of pounds. Studies that we've done has looked at the reduction in A&E attendances, looked at the number of illnesses that will be reduced by the initiatives we're already following. So therefore, I've got a great confidence that our work is going in the right direction. But I'll get back to you on the detail of the straight line graph, which takes us to 2030 or not, at a later date. Thank you.
Thank you for that. Did you want to say anything on this, Kevin?
I'm going to bring in Vicky Hobart just to reflect a little bit on the data. But before I do, Vicky, I just wanted to underscore just how important the progress that we're making on reducing air pollution and improving air quality is across the region. It's valued by our NHS partners, it's valued by our most vulnerable communities across the city, and making these big public health actions, taking these big public health actions which are generating and improving population health is difficult. Right? Our journey to reduce smoking, or journey to improve the quality of our air, these are difficult political and programmatic decisions that have had to be made. But we're beginning to see the benefits, both in terms of, as you've mentioned, Tom, the reduced pressures on acute respiratory conditions in the NHS, better quality of life for residents, and as the understanding of the impact of air pollution on not only physical but mental health is developing, indeed we're making and having an impact there as well. So I just wanted to, in a sense, situate the importance of this work, challenging as it is for public health as well. Vicky, did you want to?
Thank you. So I suppose I was just to draw attention to the data store, which is where the emissions data is kind of published from the monitoring system. My understanding is we have made significant progress around nitrogen dioxide. Particulates remains more challenging. And then really just to reflect, the Chief Medical Officer report did signal a number of areas where we need to, to maintain this focus. So electrification of vehicles, particularly light vehicles, public transport, and there are commitments that Transport for London are taking forward in that space. The need for innovation, continued innovation, the Chief Medical Officer was drawing attention to, particularly around particulates, vehicle brakes, etc. And the importance of local urban planning. So we touched on here super zones, the need to take this down to a neighbourhood level to understand what the emissions are, particularly around schools and healthcare settings. And I think there's a number of examples in London where that local neighbourhood level action is starting to take place. Recommendations around agriculture, maybe slightly less relevant to us in London, but then also a call for the NHS to make its contribution by halving its contribution in a decade. And I would say, the partnership working through the Air Quality and Health Programme Office has been good. The air quality alerts that were launched recently would be an example of that, what that kind of work is producing. Yes, I'll wrap up there. Thanks.
Two of my colleagues want to pick this topic up with you further, and I'm going to bring in Assemblymember Best, please.
Thank you. And if I could just quickly swing back to super zones. And Jazz, could you let me know how many school super zones have been implemented without a CPZ within that area?
Sorry, without a
CPZ, a controlled parking zone in that area?
I don't have that information specifically, but I can certainly ask for that assessment to be done.
Could you, I think that this is something I've brought up in previous committees, could you make sure that you do look into that? It's a massive issue in outer London boroughs where a controlled parking zone is not appropriate or would be rejected by residents, but you can imagine there's schools sometimes, as you described, schools connected to through schools, which are at those times of the day, schools at the time become a different kind of area, and it's always been a blocker that these are the kinds of areas that are not going to have a controlled parking zone but could really benefit from some of that work. And I wondered, and I think the answer is no, if you've got free without a controlled parking zone. So if there's free, so I've always been told that that can't happen, so it would be good to know how you've got through that barrier of doing a controlled doing a school super zones without. And I'd be interested to know if Assemblymember Harani has achieved that, because I was told it's never been achieved with restrictions at school times. So I don't know if you're talking about perhaps other elements of the super zone.
Maybe we'll take evidence.
We can come back to you on that.
Yeah, well, it's hard when I'm trying to get. I'm getting. Okay. If I could move on now to you, Tom, if that's okay, to pick up on the new report we saw last week from the Mayor on air quality, which was released with old data that obviously everyone on this committee would have seen. You would have seen the latest data within that on air quality goes up to January 2023. The report seemed to suggest that perhaps, or sorry, the report didn't suggest, but the media articles suggested that this was to do with ULEZ expansion. Were you part of that report at all? Could you comment on that?
I probably can't comment on that report. Yeah, so therefore that report wasn't written by the health team. It was written by the probably environment team. So, but obviously, we contribute the data to the reports, and most of the data, wherever possible, is taken from London-wide data sources.
Yeah, and that data was from January 2023. Yet it seemed in the Guardian article, particularly, to be talking about policies that had been implemented 6 months earlier. I don't know, did anybody in the health team get a chance to input in that report?
Not personally, no, but I can take that away.
But we can't. I mean, I can take that back and just try to explore that further if that would be useful.
I mean, I would be hoping that somebody on the health team would be able to talk about it, obviously, with the direct impact on health that it would have. Did anybody want to talk about the fact that the media reports implied that there was a benefit from the ULEZ expansion without showing any data from the ULEZ expansion?
It's quite hard to comment what the media might have implied about a policy.
What the Mayoral press release said.
Yeah. So, I can't really comment on that. I mean, so I can, agree that there's certain dates whereby if the date of the ULEZ expansion was in the summer of 23, therefore you're looking at that as the timeline to look at impacts of air quality for that expansion, although obviously the ULEZ was initiated many, many years ago, and we do have evidence of the impact of the initiation of the ULEZ from inner London to centre London, and now outer London as well.
Right, so we couldn't be able to make any assumptions about the outer London ULEZ expansion from data from January 2023?
Not having read the press release.
You don't have to read the report, just the general statement. We couldn't make any assessment of the progress of the outer ULEZ expansion from data from January 2023.
So I would always say that if you're looking at the impact of an intervention, your evaluation has to be designed to make sure the timeline suits the intervention and consequences thereafter. Yeah, that would be a fair way of doing a scientific study, yes.
Yeah, so without the consequences thereafter, you couldn't make that assertion.
Yeah, I'm speaking very generally here without having seen that article, but yeah.
Okay, thanks.
Sorry, I did see the press reports, and in fact, I think I may have commented on the impact on social media. But there are two things that struck me. First is the comparison between central and inner London, the impacts on central and inner London. And then they also presented data comparing the reductions in air pollution with other parts of the country, demonstrating that the change in London was much greater than other parts of the country. And my third reflection from the report, again in the media, was the reflection that the cause of the reduction were a number of factors. And in fact, in the Guardian article, from memory, did say that in addition to ULEZ, other traffic calming measures, etc., were responsible for this change. So while the health team were not involved in the report, a report of this nature showing this kind of impact is of interest, which is why I think I also saw both the report and the Guardian article on the weekend.
Yeah, and I appreciate the context, Kevin. Unfortunately, the headline did not read as your comments just did then. It led with ULEZ and only ULEZ. Thank you.
Assemblymember Russell, please.
Thank you. I hope we can all agree that any measures that reduce the amount of pollution in the air are helpful, and I can see that attributing this to this specifically is complex, but actually every time a tyre goes round on the road, more PM 2.5 particle pollution comes off, and that is health damaging. So all the measures to reduce driving are extremely helpful. But my question is about the living wage city commitment. So there was a target to lead the campaign to make London a living wage city, targeting accreditation of an additional 1,600 employers, lifting at least 48,000 people onto the real living wage, putting £635 million into Londoners' pay packets. So what progress has the Mayor made towards the commitment of making London a living wage city? And I don't know which of you would feel best able to respond to that one.
So I'll probably take that, actually. So the milestone at this present time in November 23 was 1,000 new London living wage employers, and we've hit 1,362. The milestone in November 23 for the number of Londoners uplifted to the living wage of £13.50 an hour was 50,000 Londoners. We hit 57,846. So therefore, I would see that as a significant success. I want to talk about the health benefits and the health partnership role in that. What we also know is that for people on a low wage, for every £1,000 a year that you raise their wage, you improve the male life health expectancy by 6 months. So you're making a big difference to that person's life. Secondly, what we've also recognised is the number of people living in poverty in work is increasing. Now in London, 74% of people who live in poverty are in working families. Therefore, focusing on the London living wage is a real way of bringing Londoners out of poverty and improving their health. Also, it improves job satisfaction and retention of work. Now, the NHS, this is where we talked earlier, I mentioned earlier about the partnership approach. What were the 4 pillars of the way City works? And one of them is partnership. So we've taken this to the London Health Board to say, how can our health and social care colleagues, work in this area? So the NHS trusts said there's 35 in London. We're going to get about 28 of ours to become London living wage employers by January this year. But in fact, we hit it by 30, exceeded that target, and I'm very proud that the NHS did that. Also, altogether now, we've got 165 health and social care employers who are London living wage employers. The work we're doing on this are the fruits of that kind of partnership approach that is mimicked in other sectors completely, and that's how we've achieved a milestone of exceeding 1,000 new London living wage employers by 362.
Thank you, and that's all really good stuff. And we know that in-work poverty is a huge problem affecting so many Londoners. So the more London living wage employers that there are, the better. In the Health Inequalities Strategy Progress Report in 2022, the Mayor established some further stretch targets, including lifting 75,000 more Londoners onto the real living wage by May 2024. So what progress has been made in reaching that stretch target?
Okay, so the figures I've given you are to November last year, so that was 6.5 months before the May target. So therefore, since that November, and I've just got the latest data that I can get my hands on, it's progressed further. So I can get to you, what's happened as up to date as possible, after this meeting. But so the figures I've got, so I was looking at the figures and trying to say, where do I have accurate data that I can confidently give you, and against the trajectory at that point. So the area that I've been got data which is I am confidently it's accurate, is from November 23, which is 2.5 months ago. But I will get you further data as we move forward. So I am confident that that figure has definitely increased and is definitely going towards that target. But I want to give you accurate data.
Okay, and can you just remind me the November figure again? So
for new London living wage employers, 1,362. New people lifted to the London living wage, 57,846.
Okay. So the stretch, and I accept it's a stretch target. It was getting 75,000
by May.
Londoners by May. Yeah. So, it'll be very interesting to see that the latest data when you are able to present it. Thank you. And then I want to pick up on another of the target, which was to support London action on tackling structural racism as a determinant of health by organisations in their commitment to be anti-racist. So, what progress has been made towards the establishment of the Anti-Racism Practice Learning Hub as set out in the Healthy Communities commitment of the Health Inequalities Strategy? Is that for you, Kevin?
This one's for me. So we are really pleased to have had a focus on tackling structural racism as we emerged from the COVID-19 pandemic and saw almost in real time the impact of the pandemic on widening inequalities, the impact on trust and confidence that communities had in statutory sector organisations, and issues related to the pervasive impact of racism on the lives and outcomes for community members. So as part of the revision of the Health Inequalities Strategy and our implementation plan, we really wanted to have a strong focus on anti-racism. The LARCH, the London Anti-Racism Collaboration for Health and Care, was actually launched in November of 2023, and this followed an extensive process of co-production with local communities, statutory partners, to both scope the nature of the work, identify key priorities for the collaboration, and to think about key outputs and outcomes. The LARCH is one of a range of interventions that we've put in place collaboratively on anti-racism, and these include the identification of an anti-racism champion, Marie Gabriel, on the London Health Board. It includes collaborative work between statutory agencies to develop a systemic and strategic approach to tackling anti-racism in London's health and care system, which was also published last year. And it also includes the commissioning of research from the Institute of Health Equity to further understand the both nature and impact of racism on health and health outcomes. Now, with the launch of LARCH, we're really pleased that we are just completing the commissioning of a delivery partner on LARCH, and we would fully anticipate that this will be completed and the work will begin in the next financial year. Some of the key priorities for the programme will be sharing best and promising practices across statutory and community partners on anti-racism. Second, collating the evidence on what works and ensuring that we're doing a better job on sharing and disseminating best and promising practices. And finally, building a community of practice, because this work on anti-racism is challenging and it's difficult, and it's really important that we build communities of interest and practice that would provide tools for education and building their skills, and we're creating supportive environments. With the LARCH, we're going to also have the opportunity to have new ways of measuring the impact of our work, for example, through the development of a Race Equality Maturity Index, as well as develop tools for capacity development, including blogs, resources, and other comms on the importance of tackling anti-racism. So in summary, really pleased about the journey we've been able to make across the region on this. There is not a meeting of the London Health Board that happens that we don't have a discussion on inequalities. And Marie Gabriel, in her role as anti-racism champion for the London Health Board, has been proactive in helping us to drive progress in this area. And does the sort of partnership work that you talk about sort of extend into, well, for instance, anti-racism and policing is, policing is something that comes under the Mayor's purview. And I just wondered, is there any kind of link with policing in terms of this strand of work? So through our Health in All Policies approach that I'm sure you'll hear about and we'll discuss further this afternoon, we're working with other parts of the GLA group to understand how our collaborative endeavours on health improvement and tackling inequalities can be strengthened. And a key part of that is ensuring that conversations about anti-racism are also held in that space as well. While we do not currently have an active programme of collating and collaborating on anti-racism across the group, we have raised this as an issue for further development. The priority for this year has been to establish the sort of ways of working across the health and care system so that we can be a strong and a robust partner as we begin to understand what's happening in fire, with the police and other sectors as well. But it is certainly my ambition and our ambition that we will collaborate, because all of those other sectors are both committed to this work, but we're all on different paths of the journey when it comes to conceptualizing, implementing programs and evaluating the impact of our work.
It certainly feels like an area, particularly around policing and young people and the kind of links across into safeguarding, vulnerability, violence reduction, preventative approaches. There's huge kind of public health link-ups in terms of what's going on in policing and the thinking they're doing about how to reduce disproportionality in the impact of policing on black and minority communities. So it would, seeing where that develops over the next 4 years will be very interesting to see. And then my next question is about active travel and the target that by 2041 all Londoners will do at least 20 minutes of active travel every day that they need to stay healthy. So this is about all of us doing lots of brisk walking on our way to catch the bus to travel in here. So in 2022-23, 38% of London residents aged 20 or older achieved at least 20 minutes of active travel every day. Before the pandemic, this rate was around 40%, so it's slightly down still from the pandemic. And I know everyone, during the pandemic, everyone was staying at home, not travelling so much. And it's interesting that even now there's a slight percentage drop in terms of everyday active travel and everyday physical activity. So what action is the Mayor taking to increase this figure, given the commitment in the Health Inequalities Strategy to raise levels of active travel?
So if I start and colleagues will come in. So and again, I think what you remind us is that it's only a couple of years now when we were in lockdown, when COVID came virtually out of nowhere and devastated our city, and it had a massive impact. And not only did it have an impact on our health system, but it changed the way we worked. And I think what you definitely will find is that there's more people now working from home than used to be the case. A lot of people's active travel was based around them travelling to work. It was always the idea, maybe get cycling to work or getting off the bus or tube a bit early and trying to build that active travel, an activity into your daily work. And therefore that change in the working pattern definitely has an impact. So the good news is that 38% is the figure from 2023. But in 2022, it was 35%. So we are now back on an upward trajectory of the percentage of Londoners doing 20 minutes per day, in London. Also, our cycling figures are going up, 20% increase since 2019, and that's across all groups of Londoners. Walking trips per day, and it used to be in 2018 the average of 0.66 walking trips per day. Now it's up to 0.84. So therefore there is a growth, and hopefully we're moving back towards the figure we were before the pandemic. But one has to recognise the way we live and work has changed. What we have tried to do is, I'm thinking of the cycle networks. Active travel is walking and cycling. So I think what we've done since 2016, in 2016 there was 90 kilometres of cycle highways. Now we've got 350 kilometres. we've now got 500 school streets. The idea there really is that can we make it that your journey to school a safe journey to school, so therefore you can make sure that there's cars aren't there, so you have to bring your children to walk to school. Also, school super zones really encouraging that. Also, we have really pushed the idea of free cycle training, because people are very anxious often about cycling on busy roads. And so you can design your roads accordingly to make sure you're separating the cyclists from the vehicle. But also you want to make sure people are trained and given that confidence. So I think that there are many things we are doing, and there are some green shoots of recovery in active travel. We'll just hand over to Kevin if Kevin wants to add comments as well.
Nothing additional from you, Tom. I think you covered it.
Okay, I'll just briefly come back with one thing, which is, the overall target is for everyone to be getting their 20 minutes of physical activity a day by 2041, and we're still well under 50%. So, are there any interim targets, or are we still looking just at that 2041 target? It's just, I suppose it's for the mayor to be able to keep on track, and obviously we don't know who's going to be mayor after the election, but it's about keeping track of our progress and understanding whether we need a step change in delivery on on quietening down our streets, of kind of reducing the amount of traffic, making it more likely that people will walk and cycle and feel confident to cross the road. Have you got any plans for interim targets?
And so I'm going to hand over to Vicky in a second, but I think you're right to say that when you're faced with a changing kind of architecture of the way we travel and live our lives, you've also got to change how you want to achieve those long-term goals. So I think we have to revisit how we work. So I'm going to hand over to Vicky now, who'll give us some more details on that. And that challenge you give quite fairly is that we've got to do something different. If people are working differently, we can't just say make walking as part of your journey to work if you're only working in the office 3 days a week. Sorry, Vicky.
Thank you. So I think there's been a task to understand, as we come out of COVID, what are the patterns, and understand the data. I'm not aware of any interim targets at this stage at the electoral cycle, but I'm happy to go back and kind of have a look into that. What I would say from a public health unit perspective, how we work with the transport team and TfL, we've also been looking at, from a slightly wider perspective, there's a lot of interest in active travel and the contribution it makes to health and well-being. Obviously, we had the great session last year with the Assembly, where you were doing a bit of a deep dive into this area. Road harm reduction remains very important, and the vision around zero road harm. We held a quite proactively attended convened with directors of transport from the boroughs, with local public health directors and Transport London in the autumn, to look at how that agenda is being taken forward, because that is a barrier for several people kind of engaging in active travel. And then there's a range of data coming through, for example, on the cycle scheme, an interest in e-bikes and the kind of uptake of those. So we're also seeing some modal shifts as well in terms of use of public transport.
Okay, thanks. Well, I look forward to seeing some nice interim targets coming forward in the new mayoral term. Chair.
Thank you. Assemblymember Best.
Thank you. I'm not sure who this question is best for, but I'm going to pick up still on the active travel arrangements. So when it comes to TfL funding for schemes at the moment, where, for example, with things like Copenhagen crossings, which I'm a fan of, but one of the things that I think is really important is putting a pedestrian priority sign alongside those crossings, which isn't currently part of the allocation of that money, and it's hard to get that traffic management order in to actually have the Copenhagen crossing with the addition of a pedestrian priority sign. Can TfL look into the awarding of that money? I suppose this is for you, Emma, sorry. When we award for Copenhagen crossings, can the design of Copenhagen crossings now have a pedestrian priority sign as part of their implementation?
Vicky, do you want to take that one?
Oh, Vicky, sorry. I saw you scribbling, Emma, so I didn't know whether...
I can take that away and come back on that one.
Sorry, that's a question for national government because it's about the road sign regulations, and they are all controlled by the Department for Transport. So actually, I agree, it could be really helpful to have that, but it's something we'd need to take to government.
So can we lobby to get those conditions enforced?
I'm happy to take that one away.
Yeah. Okay. So the other question I wanted to ask was around obesity rates within children, which has come down a percentage point this year, which is good news. But we still had 3 London boroughs in the top 10 of worst rates in the UK, specifically Barking and Dagenham being the worst. So I wondered, and I want to move away from talking universally and talk specifically at targeted intervention with for example, Barking and Dagenham, and what the health team are doing there.
Thank you. So yes, there are interventions that are led by boroughs, and so the actual activity that drives the changes at that local level is led by boroughs, and it's part of their public health roles and functions. The work that we're doing is in support of boroughs, and then offers a more universal approach. So I think you're focused to us to kind of answer questions about what targeted activity can be done. Yes, it's for the boroughs to take that targeted activity in places where they need to prioritise it. That said,
well, that's not what we would do in other areas. Sorry, Jazz, but we would target in other areas. We would look at certain schemes for certain areas. Why would we not have the same approach here when it's quite clearly the link with deprivation and obesity, and we know the areas? Why would we not be looking to target, support, and help those councils?
Yeah. So. Continuing my answer then, there are the work that we've been doing through super zones and quite a lot of the work that we're doing across a whole range of other initiatives. For example, some of the kind of the work that we've been doing supporting breastfeeding, for example, and some of the other interventions that we know are going to support local areas. We've been targeting exactly those sorts of areas. So the issue alongside those areas with high levels of deprivation, the fixes or the interventions are just going to have a much deeper, a much longer time to have impact because the depth of the problem is so deep. So this is part of the nature of dealing with deprivation and working in that kind of environment. So the targeted work is going to take longer to show impact, and it is going to have it's going to need a much broader range of interventions. So that will be the targeted approach that we take. So all of those programmes, super zones, healthy schools, all the work that we've been doing around, say, for example, the healthy catering commitment, breastfeeding, all of these sorts of programmes are targeted in exactly those areas because those are the areas that suffer the poorest outcomes in terms of childhood obesity and also, unsurprisingly, high levels of deprivation. So that is where we're targeting our interventions, but the impact of those are going to take longer to bear fruit.
And when would we be able to see evaluation or feedback
of those programmes? So super zones is due to come shortly.
Yeah.
I say shortly just because it's one of those. It's at some point over the next few months. And some of the other programmes, again, there are a whole raft of evaluations currently happening because, of course, these are all of interventions that began more or less at the same sort of time.
If I can add as well, is that so I think I echo your approach, which would be that we should be targeting our resources to where the problem exists. There's no point, let's say, targeting areas to improve life expectancy in Richmond. Whereby the poorest life expectancy maybe is in another part of London. The area I suppose I would pick out of this was the Child Obesity Task Force Action Plan, which had a number of interventions which in fact we have tried to follow accordingly, and what we've done in those is to make sure they're targeted in a way they address the inequalities that exist and will therefore, let's say, help with Barking and Dagenham. One example which has had a degree of evaluation, let's say, was the ad ban in the TfL network, reducing the advertising of high fat, sugar and salt foods And what we've seen there is the reduction in calorie consumption of families that were travelling on the tube, and also that reduction.
Sorry, Tom, if you don't, we probably don't want to get into an argument about the junk food ad ban. I mean, if you want to go there, I'll go there, but I don't think the committee wants to hear it on our last term, and I won't hear you say it didn't. It showed a projected less rise. It was still a rise. It showed that there was a projected less rise. Shall we not go there?
I think the committee has had a great depth from the
and I enjoyed it immensely. So the point I'm trying to make, I suppose, is that some of our universal approaches will have a targeted effect if they're addressed at areas whereby we know that's the driving causes of child obesity. I wasn't talking about was water-only schools, a daily mile, active travel and increasing activity, etc. We do try to focus on our most deprived areas, and therefore that is a targeted approach.
Okay, thank you. So I could go on to ask why it is that the areas that have the most TfL signs are the ones that are in the worst position when it comes to obesity, and those without as many TfL advertising signs have less rates. But anyway, let's leave it for today. I wanted to ask about the Health Inequalities Strategy implementation plan, which runs between 21 and 24. It will end in May 24. So is it your expectation that there'll be another updated implementation plan at that point? Is that something that work is beginning on, or is that something that you are waiting for a new mayoralty?
Well, given the timing, as you rightly identified, it might be prudent for us to wait until the new administration is in place. But it is clear that there are some key principles that we are poised to build upon that will guarantee, I think, great success for the next phase of the implementation plan. I began today and I spoke about the architecture that we have in London for health inequalities, which is very different to what existed 5 years ago. The London Health Board, the Health Inequalities Group of the London Health Board, and we are just establishing in the NHS a Prevention and Equity Group. All of these governance groups are enabling us to work more collaboratively and to work in stronger partnership. We've learned over the past 4 years the importance of data and evidence, aligning priorities, developing our programs, the partnership working, and having an agile approach. So again, those principles we take into a new plan. And then finally, we have signals of what works. So super schools, super zones, universal free school meals, the wellbeing champions, or work on air quality, or work on anti-racism. So while not preempting the content of the next implementation plan, we certainly have key principles, the governance, and emerging best practice that we will be able to build upon.
I think you've talked today about the delivery and structures. Is there anything else you'd want to add to the key priorities in terms of the next mayoralty addressing health inequalities in London?
A couple of things. We are on a journey of strengthening the ways in which we're engaging Londoners and communities. We learned a lot during the pandemic about the importance of building on trust and confidence, and I'd definitely like to see us do more of that in the next implementation plan. So working across the GLA with other groups which are touching the lives of Londoners to engage them in that journey on health inequalities. And then second, as we've emerged from the pandemic and gone through the cost of living crisis, we're having clear signals about some health issues which are driving premature mortality or early death in Londoners, and this includes heart health. And as a city, we haven't done a lot pan-regionally on engaging Londoners about getting their blood pressure checked, staying on their meds, making sure that they're taking care of their hearts and minds. And that could be an important next step for us to think of in terms of how we get Londoners re-engaged with this. And this links, I think, very well to the question asked earlier about active travel. Post-pandemic, a number of the behaviours that would help all of us to be healthier, or alcohol intake, or physical activity, eating well, really took a hit during the pandemic. So I think in the next implementation plan, a bit of focus on that healthy lifestyles would be in order. Thanks.
Thank you, Kevin. And whoever the next mayor, I'm sure they'll find your guidance as a statutory health advisor on these helpful.
Thank you.
Great. Thank you. I think we should help every Londoner to get a blood pressure machine so they can monitor their own blood pressures regularly and reduce the workload on GPs. Let me bring in Assembly Member Andrew Boff, please.
I forgot myself there, so you're not alone, Dr. Coffey. To Ms. Hobart, the GLA Group Public Health Unit has now been in place for about 2 years. Could you update the committee on the progress it's made in implementing the Health in All Policies approach across the GLA Group?
Thank you very much. So it's a pleasure to give a bit of an update from when we presented previously to the committee about the establishment of the unit. And just wanted to pause and say thank you to committee members that have attended the forum meetings as observers. I think that's been really, really helpful and hopefully given a good kind of two-way flow of information. I'm pleased to say we've made some fantastic appointments, bringing in some really good people that have a lot of relevant expertise, but have also rolled up their sleeves to understand how the GLA group works and how they can best support the group. So that's been fantastic. Some of the highlights, I think, have been around the forum meeting and looking at some of the areas where we can get better strategic push and alignment across the group. So particularly we've looked at mental health, we've looked at violence reduction and the new duty, and we've looked at tobacco. In terms of taking forward health and all policies as an approach, we've started to develop the overall programme to that, both through skills development and bringing people together. So we held our first masterclass. We're commissioning some induction materials for different teams, as well as strengthening the relationship with the organisations, the bilateral conversations that we have with them. We've been working with those organisations to look at the levers that they have to improve health. So we've developed a levers framework, which I think observers at the meetings have seen several times, and we are trying to use that levers framework as a way of garnering learning as we go forward across the group, and that looks at how we can understand what the health issues are, how we can advocate, and how we can then take action for the different group organisations. We set out some criteria really to look at benefits realisation, and we're actually taking that back to the GLA Collaboration Board soon, and that was looking at strategic collaboration, how we mobilise advice and support, how we influence for complex and wicked issues, how we develop as a centre of excellence through engagement with other cities and as an area of public health practice, as well as providing a more resilient kind of public health function for the group. And there's been lots of progress against those. And then finally, we're organised, as you'll recall, into 5 kind of portfolio areas that are looking at the areas where we hope to have the biggest impact on public health outcomes. So looking at housing, community safety, transport and air quality, planning and the environment, as well as economy and culture. And there's lots of rich examples of how those relationships are developing and delivering across a range of areas.
So when the policies are developed, so for example the Mayor's transport policy, perhaps the Mayor's housing policy, are you in the room? Is the public health unit in the room when that's being developed?
So I would say that varies depending on the strategy, the development of the strategy, where it is in that phase, whether it's a new area of policy development. So I would say that's a varied picture. We are certainly looking to strengthen that through development of skills, so supporting other teams that will be considering health impacts in their work. So I don't think we don't always have to be necessarily in the room. And certainly that, given the breadth of what the GLA group is achieving, that will be challenging.
I mean, not for every decision. I'm not expecting you there for every decision, but I'm trying to get an understanding of how the rest of the organisation is talking to the public health unit to make sure that they don't come up with a policy that doesn't have health in it. And we've seen a few of them, which doesn't have those considerations in them. So I'm trying to understand the working relationships that you have.
So the working relationships, I would say, are still evolving. They're stronger in some areas than in others, given the history of the strategy and the opportunities to work through. The offer that we're developing as a unit in terms of skills development is there and universally, and the forum is playing a really helpful role in promoting that. So, for example, through all of the exec directors across the GLA group that participate in the forum, that's been really, really helpful in spotting some of those opportunities.
And how do you work with TfL?
So the relationship with TfL is, I would say, strong. And again, it will be across a range of issues. So some of those are around policy and strategy, but that would be with the transport team and the environment team in the GLA as well. And some of those are quite bespoke public health advice, given the public health needs of that organisation. So an example of that might be we worked with them to develop their smoking cessation pathway for their staff, would be an example. That was a priority for them. And we facilitated and worked with them to develop that particular pathway.
So it still sounds to me like a bit of a work in progress, that you've got a lot more developments to take place. Is that a fair analysis of what you've said?
I would say the prioritise, and I'll hand over to colleagues in a minute. From my perspective of having got the team together, the issues around prioritisation will be key. Clearly, we'll be re-looking at that with the next administration, but also bringing expertise around where some of the biggest public health gain could potentially be, as well as where our health and care partners want to explore areas with the GLA group. I don't know if colleagues want to...
Well, I was going to come on to Dr. Coffey about whether or not back in November 2022, you said that the PHU will take a systematic approach to public health interventions across London. How has the PHU done this to date?
Yeah, so I was going to give a couple of examples, really, which might kind of bring alive the policy. So this morning, I was co-chairing the London Drugs Forum with the Deputy Mayor for Policing, Sophie Linden, and this again is a joint approach, a public health approach to how do we address the health harms and the criminal justice harms coming from drug use. And in that area, as an example, I like to give a few things that we were talking about today. The continuity of care. How do you make sure when prisoners who've become drug dependent leave prisons, how do they go seamlessly into a drug service? How do you make sure there's an effective court diversion service into a drug service? How do you make sure when the police identify someone who is in custody who has a drug issue, how do we make sure that they are led into the health service? And by having that joint work, and the public health consultant, Farah Hart, is pivotal to that work. She's the kind of the bridge which has brought the health team together and the MOPAC and the police team together. Second example I would give is a board called the Life Off the Streets Executive Board. That's chaired by Tom Copley, the Deputy Mayor for Housing, and then I sit on that board. But also it's supported by Emma de Zoet, who's the public health lead in housing. And so that group has looked at rough sleeping. How do we make sure we address rough sleeping? How do we update and alter the severe weather emergency protocols? How do we make sure that, in fact, in the summer of last year when it was so hot, how do we bring a public health kind of input into how we assess cool places and getting vulnerable people out of harm's way? And so that kind of relationship and that role is replicated with many of our deputy mayors. Is it reached a point where I can say, done and dusted? No. Do I say we've progressed phenomenally since November 22? Definitely. And I see real concrete examples of those improvements. And when you talk about the health and our policies, so it works both ways sometimes. So it's not just about how do we make sure that the policies that, let's say, the transport team are doing for the transport system for London, but it's also about, these are big employers, TfL, Met Police, the London Fire Brigade. How do we make sure we use our responsibility as an employer and use our public health expertise to improve the outcomes for those employees? And finally, I suppose, it works both ways. So a big priority of the Mayor is violence against women and girls. And what we know is that the health service often is a perfect time to intervene, often be it a GP appointment, an A&E attendance, maternity services, sexual health services, drug and alcohol services. Often in those episodes, patients reveal their domestic violence and assaults. And we are now working with MOPAC and the police of how can we make sure that we use those health touch points to escalate and intervene to reduce and address that domestic violence and that violence against women and girls. And that, again, is a joint work, this time us using the health to assist us in the work to address violence against women and girls. So I am very pleased how it's progressed. It's not fully there, but it has gone a long way. And when I talk to my deputy mayor colleagues, they very much say to me, Tom, we recognise we have a role in improving the health of Londoners. And when I talked to Deputy Mayor of Housing recently and about people in private tenancies, recognising the often poor conditions that they live in, and he knows that addressing that will improve the health of those people. The problems of damp in our houses across the country and in London, addressing that improves the health of Londoners. That is a housing intervention. It's not me or Gonka as a GP, and so I actually think it has made big strides.
I mean, it's an interesting point you make about housing, because for as long as I've been involved in politics, we've had silos which don't talk to each other. It's the same now, and it's breaking down those silos. With regard to people being let out of prison who are maybe drug abusers, there's a particular issue about women being released from prison, where they then go, and perhaps you should have a word with Tom Copley, because I'm pushing him very hard to get the boroughs, because of course the boroughs have got their own responsibilities and everyone's got pressure on them. With regard to the violence against women and girls, I think it probably needs a commissioner to look after the interests of women in this city, because they're not feeling especially safe at the moment. I mean, moving on to another point, perhaps you can give some highlight. Are you concerned about the rather low vaccination rates for measles, and what have you done to address those?
I'm going to probably say yes, I am concerned about it as a GP.
Sorry.
I should leave it on. As a GP, as a parent, of course I am. But the expertise in this area definitely lies with Professor Fenton.
Professor Fenton.
Thank you very much. I'm very concerned about our low vaccination rates in the city. This is not new. London has been on a downward slope in terms of our uptake of childhood vaccinations for more than a decade. And as I'm sure you're aware, we have some of the lowest uptake rates compared to other regions in the country. This is the result of a number of factors: the size, complexity, demography, population turnover and churn that we have in the city. It's consistent with other large global cities, which also have low vaccination rates as well. But these low vaccination rates have a material impact on the resilience and the vulnerability of the city to infectious disease outbreaks, especially preventable childhood illnesses such as measles and, of course, whooping cough and others. The current resurgence that we're seeing in London began in the spring, summer of last year. Currently, we're observing clusters and small outbreaks across the city in pockets where vaccination rates are low. We're not yet seeing the same epidemiological pattern that we're seeing in the Midlands, which has been a very steep and fast rise in measles cases, in part because they have even lower vaccination uptake rates in population subgroups in the Midlands, and that's where the infection is spreading. Now, what are we doing about it? a few things. Number one, we have a measles incident management group, which brings together the NHS, UK HSA, OHID, GLA, the health and community partners to really focus on how do we get our vaccines in the arms of the kids and in families that need it, and how do we create whole system approaches, especially building on the lessons from COVID, to engage some of our most vulnerable communities. That meets regularly, it looks at the data, gets the vaccine out, and has a very active program of looking at our progress. Second, I chair the London Immunisation Board, which is NHS London's board that oversees all vaccination programs to help to drive up uptake of vaccines, and that works with our ICBs, local government, on our strategic and operational approach to improving vaccinations. The third thing we do is really advocating with national government, so that national government is both identifying opportunities to support our work on vaccines, as well as to ensure that there's good national campaigns on vaccinations, one of which was launched only last week. So we're doing a lot of advocacy with national government, with UK HSA nationally, to help with the situation in London.
Thank you.
Pause there.
Thank you very much, Professor Fenton. I was wondering, how could the London Health Board be used to promote these messages?
I think there are three ways which the London Health Board has already been helpful, but which, working with our partners, they'll be able to really make that difference. So the first is that we have used the London Health Board to provide updates on our progress with responding to both measles, mpox, and other infectious disease outbreaks. And that enables us to inform our partners and to ensure they're aware of the implementation or corrective actions that we're putting in place across the health and care service. So that leadership alignment is important. The second... Okay.
Sorry, small cock up on my part.
That's okay. So the first is ensuring that system partners are aligned and aware of the outbreaks and are therefore informed about what we're doing. The second thing that the London Health Board does is that it enables us to work with the leads of various statutory organisations and partner organisations to leverage their assets of engagement with communities, communication, mobilisation of communities, and that's really critical as well. And then the final thing that we would ask the London Health Board to do is to help us with that advocacy for the resources that we need to ensure that we're delivering our programs effectively in the city. Sometimes it's staff, human resources. At other times it's about how we collaborate, building on, again, on some of the lessons that we learned during the COVID pandemic.
Thank you. I apologise to Assembly Member Hirani. I just ran on, I'm afraid. But before I depart from this, why don't I see public health messages on TfL, on the tube?
That's a good question.
If I go to London Bridge,
I'm a bus taker myself.
As I go to London Bridge and I walk past the donut stall and I see absolutely no advertisements about healthy eating, about vaccinations, about the progress that's been made on HIV in this city, something we should be really, really proud of. I don't see anything, any public health messages at all on our transport network, and I want to know why.
Yeah, so in fact, I did recently see messaging regarding HIV and getting HIV testing on the TfL network, as it happens.
We don't go to the same stations then, that's all I can say.
I mean, we obviously don't.
No.
Okay, secondly, so TfL obviously is an arm's length body, and they make their own commercial decisions regarding, how they, what advertising they will receive and how that wants to be funded. I would welcome the NHS and Public Health England, and OHID, etc., kind of having a discussion with TfL to advertise accordingly, and so that there definitely is an open door there.
Well, who's the chair of TfL? Perhaps we should ask that person.
Yeah, so I think the TfL makes commercial decisions as well. The NHS has got an advertising marketing budget, as does OHID. So I think there is definitely a conversation to be had to say, is that an appropriate vehicle accordingly? And on your suggestion, maybe we can facilitate that discussion.
Well, let's just go back in time a little, because the Mayor had said that under his instructions, TfL provided free advertising space for a COVID-19 campaign. Now that suggests to me that he has the power to do that if he chooses to. And yet now we get the response that they're independent, it's all commercial decisions. I honestly think they could lose a few adverts for, I don't know, whatever, on the tube, supposedly low-fat burgers that I see on the tube. They could lose a few of those in order to promote health messages, which we all agree are important messages, don't you think?
I think you made your point, right? But I would say that the obligations for health messaging sits with the NHS and not with the TfL. They should make the decision to invest money there.
In which case the Mayor was on the wrong territory when he said that on his instructions, his personal instructions,
I think the COVID-19 pandemic was a once-a-generation event, right, in public health.
I pretty echo the points that Dr. Sahod said, was that COVID, it was a very once-in-a-lifetime event, and in fact, there has been also mental health campaigns.
Well, people should always try something once. They might find out they like it. And he's tried it once, and why doesn't he try it again?
But Andrew, well, if you're sitting on the Transport Committee, you'll be saying to the Mayor that the TfL should be working efficiently and making money for the state. You can't have it both ways.
No, I wouldn't. I would be saying TfL is there for the service of Londoners, and unfortunately it's just there in order to generate finances for the Mayor.
Let's move on.
Could you just clarify, because you were saying that the Mayor doesn't have responsibility. He doesn't have responsibility for health inequalities.
The Mayor has a responsibility for producing the strategy for health inequalities, but the delivery of that is a partnership issue, right? He doesn't have the obligation on his own.
So but it's his responsibility for the strategy and delivery.
Not for delivery, not for delivery, for the strategy.
If the London Health Board can't persuade the Mayor, who are they going to persuade?
I think the question is...
If we're not delivering anything, why are we here?
I will take that back, because there have been many campaigns on the TfL funded by different bodies regarding health initiatives.
That's only when boroughs have paid for those adverts.
And so, but what I'll take back with you. Can we have a discussion about, is that the best way to ensure we increase the immunisation rates, which myself and Kevin have both said we are concerned about? So I said at the beginning of this meeting, this is meant to be not a kind of back and forth debate. It's meant to be a team approach using your expertise and wisdom. So I will take that view and we will have that conversation.
Absolutely. Those very important graphs that we were shown by Professor Fenton showed that there is a disparity in the uptake in HIV diagnosis between different ethnic groups. Now, why shouldn't we get an advertising campaign using the TfL estate to address that particular problem? And I don't understand why. And I welcome the fact that you will take that away and feed it.
Jez, we're done with this. I also want other messages we put on the public health while you're honest, right? But anyway, we leave it there. But it's a big debate, and I think we would welcome that idea taken forward. I'm not against the idea, but the question is that the obligation of the NHS of public health rights sits with them, and public health has been weakened over the last 10 years, right, by moving an underfunded budget to local authorities, right, who have closed smoking clinics, who have closed sex health clinics in London, right, and I think the NHS is in a mess, right. But apart from that, I'm going to move on to the next Assembly Member Hirani.
Thank you, Chair. Just to pick up on something, actually, I think Dr. Surgery, you mentioned in your opening remarks about the 6 key tests, and just wondering, maybe Dr. Tom Coffey, if you can just give a bit of an overview of how often the Mayor's 6 tests have been used since the initial development in 2017, and what impact have they had on the delivery of health services in London?
So what I'll try to do is kind of do a summary as much as I can. So first of all, to say that they were developed, as you know, after a report by the King's Fund, which looked at the 6 areas, which is health inequalities, bed numbers, social care use, clinical engagement, and finances and public engagement. So they've been used probably about 5 or 6 times. Most recently, we've used them on 3 areas. One on the Epsom St Helier development. Secondly, we've used them also on the area of the cancer services moving from the Marsden to either St George's or the Evelina. Thirdly, we've looked at North West London and its new mental health service provision around the Gordon Hospital. Fourthly, we're using them also around the North Central London and the changes to paediatric and maternity services. So, and 2 or 3 of those are active at the moment. Also, in the past, we've also done a review using them at the Moorfields Eye Hospital and also at an orthopaedics review in London as well. So that's probably 6 or 7 times. And each time what will happen is we commission an external independent body, be it the Statutory unit or the Nuffield or York Health, looking at giving us an objective evaluation about how do these significant service reconfigurations impact on Londoners.
Thank you. So you mentioned out of the 7, 2 of them are live. So on the 5 that are not live, what impact did it have?
Okay, so probably the best one I can use, I think, is the one which I probably know best, is the one in Epsom and St Helier. So this resulted in a number of changes. So first of all, we looked at it, and in fact, we felt that the bed numbers, they'd got an underestimate of what we thought was needed. So they increased the number of beds to have an extra 1,000 throughput per year. Secondly, we didn't feel that the inequalities and analysis of certain parts, which is North Sutton and South Merton, was sufficiently detailed enough or had an appropriate robust action plan. So we asked them to do that, and they did. Thirdly, by moving services around, we felt they were creating areas which perhaps were missing out on service provision, particularly in certain parts of Merton, which were poorer, and therefore they developed what's called the Mitcham Health Hub, in that area. And fourthly, also, because one site was moving somewhere else, the residual services we felt needed more robust mental health and primary care services. We articulated that, and they've now become the plans of implementation. So that gives an example whereby the process we normally go through is we do the analysis, we share our findings, we ask the reviewing team to look at it and to make changes, and Sadiq writes a letter to them asking, for those changes. And to be honest, I have to say, in the main, the changes are supported, and then we follow those changes afterwards to make sure that's happened. And the health system doesn't have to agree with the process that we're following, but universally they always have. They've seen it now as almost a standard process that any significant reconfiguration in London should and does go through, because they do believe it gives Londoners trust in the process if they can demonstrate quite publicly that they're adhering to the SK6 principles and making adjustments according to an independent analysis of their reconfiguration proposals.
Okay, and just to answer that, so 2 of the 6 tests were updated in November 2022. Can you explain sort of the rationale behind that?
Yeah, so the first one was about inequalities. So what we used to have is just say, can you demonstrate that you're addressing health inequalities? And what we found was that the NHS was struggling to work out, what do you mean by that? Do we just do an equality impact assessment? So we said, no, look, we'll try to give you some examples and some processes of what you should do. And so what we asked them, what we really would expect at any proposal is, number 1, that you do a baseline analysis. Number 2, you show how your plans of reconfiguration will demonstrate an improvement in inequalities. And then thirdly, you have a monitoring process to demonstrate you succeeded in that. And secondly, we also asked to now look at their role as an anchor institution, to say that, and I think this is a term probably not used 5 or 6 years ago. What we're very clear to say is, you as a hospital system are an anchor institution for your community. You're a big employer, you're a big purchaser of services, you're a big training provider. So therefore, can you look at how you're reconfiguring to make sure you're using that power and influence of an anchor institution appropriately to address inequalities? So we put that, there were the changes for the inequalities measure. For the bed numbers, the previous one was a bit perhaps too simple. It just said, are you reducing or increasing beds? And so what we said to them, well, let's give you some more detail and a process you might want to go through. Number one, can you please do a demographic analysis over the timeline of your proposals to show what is going to change in your population? If it's going to go down, or if it's going to get less old people, more young people, that might be sufficient reason in itself to reduce beds. If the reverse is true, therefore you need to stand still, you need to increase beds. Secondly, though, you might be doing credible interventions which change the need for hospital admissions. Examples being hospital at home, intermediate care facilities in the community, step-down facilities to expedite discharge. And another good example is the Epsom Orthopaedic Centre, which is a designated orthopaedic centre, which we found reduced the length of stay by about 6 days. If you're going to have these new designated services, that in itself might therefore need to have less beds. So rather than having that bald figure of you're going to go from 1,000 and you're going to have 1,000 in your new configuration, we gave some guidance about how you would want to calculate what are the appropriate beds in your new system. So there were the two new tests.
Yes. Dr. Coffey, these 6 tests, when you apply them, is it that the organisation which wants to reconfigure the services, they contact the mayor to give an opinion, or is it that the mayor decides on which cases to involve? How does that happen?
So therefore, the process normally is that is it a significant reconfiguration, right? So usually it means, is it a configuration which usually involves more than one borough, so at least 2 boroughs, and has it got significant kind of interest from clinicians or the public? And therefore, usually what would happen is you'd get a cross-borough overview and scrutiny committee. And therefore, that in itself means that 2 boroughs have got together to say this affects both boroughs. And what usually would happen is the Health Service put out something like an outline business case, and then they do a consultation proposal. So we only look at what their consultation proposal is. We don't say, we think you should have done something different. Our role is to look at what they're proposing.
So who refers the matter to the mayor for him to give an opinion? So
we, as the health team, look at all the proposals going through, and some we say, that doesn't necessarily meet what we would consider to be our criteria, because what we don't want to do necessarily is dilute our resource, spending it on much smaller configurations, right? Unnecessarily. So we try to do things which are significant configurations which affect at least 2 boroughs, and then usually it will involve 2 boroughs already having started a overview and scrutiny committee, a joint one.
Okay. Recently, in northwest London, affecting 8 boroughs, the ICB tried to order the model of primary care in those 8 boroughs. Were you aware of that?
I was aware of it, yes.
Okay. Did that cross the board? Did it cross your table?
So that didn't. I don't think that went out to public consultation.
It didn't. But a reform affecting 2 million people was taking place. The ICB was pushing it. It has been postponed for 1 year because the uproar it created amongst GPs. There would have been a revolt right on the battlefield of primary care. And I want to know, did it cross your path?
Yeah. So therefore, that didn't cross our path in the point whereby there wasn't a public NHS consultation that we looked at. So therefore the SK6 is a process which we use to apply when the NHS goes out to formal consultation.
Okay, so the NHS obviously didn't go to consultation, but it's going to affect 2 million people, okay? And all the doctors were up arms about it. I'm now putting this on your radar, Dr. Coffey, and I want you to please keep an eye on this, right? To make sure that the NHS doesn't push it through, because all they've done at the moment is saying we'll postpone it for 1 year, okay? But it'll come up again, okay? Yeah. And I like the NHS to be held to account for what they're doing.
Yeah, no, and that's right. And what I always say, Sadiq always says he wants to, champion, challenge and collaborate with the NHS. And the SK6 role is where he will often challenge the NHS. So therefore, and I'm aware of the changes to primary care access and single primary care hubs and this kind of stuff, which I understand North West London are considering. So it is something, it will come onto my radar, and we will consider how we...
They've postponed it for 1 year, right, because of the uproar which was on the because we all refused to sign the contract as they put it forward. Okay. But the other thing is, you talk about hospital beds, right? There was a report by King's Fund, right, saying that London needs 1,600 more beds. I mean, when I started my career here at the Health Committee, it was because they were trying to cut hospital beds, and then the mayor, I can't remember which mayor, but commissioned a report from King's Fund that London needs 1,600 more beds, right? Is there a case for reducing beds in London, do you think, at the moment? Given there was a report already produced that saying London was 1,600 beds short.
No, I do not believe there's a case to reduce the number of beds in London.
Thank you.
Thank you. And Dr. Coffey, as a sort of Mayor's health advisor, I think I'm glad that you've confirmed one of the live issues that's under consultation at the moment in terms of North Central London and maternity services is one that is on your radar.
Definitely.
And I know the consultation for that is open until the 17th of March, because that's something that has been raised with me through obviously people who have used myself personally. It's an issue that is close to my heart as well, but thank you for confirming that as well. And can you ensure that you share anything that is sent as part of that with the committee as well?
I definitely will do, yes, certainly.
Thank you. Just actually still on the topic of maternal health and care, because it was an issue that we looked at as part of this committee last year. So in response to the committee's report on maternal health and care in London, the Mayor said that he had raised the issue of the postcode lottery in services that people received in London. What was the result of any discussions that the Mayor had with senior NHS leaders on this? He did agree to take it forward.
Yeah. So I'll start and I'll bring in Jazz in a second. So yes, and I was present at the committee that we discussed maternity services, and in fact there was a number of issues which came up, especially about the inequalities issue, regarding especially black and ethnic minority women and their outcomes being so much worse. And secondly, also sometimes the postnatal care and the mental health issues of postnatal care, which aren't always addressed equally across London. So what we did do, we meet with the NHS, senior management team on a regular basis, and we raise this with the chief exec and their medical director, asking them, again, this is Sadiq's influencing role, saying, but this is such an important issue that when you look at health inequalities, if you just look at some of the analysis on outcomes of maternal deaths, around childbirth, neonatal deaths, the figures are quite stark, and and NHS have gone away to see can they address those disparities. Can I just hand over to Jazz, who's probably got some more details on this area?
Thank you. The conversations have been so Larch is basically one of the kind of key things that Kevin's spoken about. through which we want to really kind of identify topics. Maternal health is definitely up there in one of them, alongside a few others. I think certainly the kind of wider conversations that the NHS is taking forward through its own network. So there is a Babies, Children and Young People's Network, and it's there that they're looking at some of the outcomes for babies, but also when they're talking about babies, they're thinking 9 months prior to that child being born, obviously. So maternal health and antenatal care is very much a key part of that. So some of the key initiatives that through those conversations we're now having continued conversations on will be around how the NHS is trying to increase numbers of women being booked in early. So the early booking, at 10 weeks of pregnancy, increasing the numbers generally and lowering that gap between those women who are more vulnerable and those less vulnerable women. So really lowering that gap. But there are other initiatives that we're talking to them about in terms of what we could be doing to identify access to those communities and ensuring those communities who are underserved by those services are more easily accessible. I think Kevin might also have some thoughts on this. No. Okay, sorry. Yep.
Just obviously because there's a live consultation as well, so is that all being drawn into that work as well?
It's for the NHS to draw that in, because obviously it's an NHS consultation, but we're very keen to support. We're involved in the wider conversation. So there is a ecosystem, I suppose, where this is all happening, and we're part of those conversations with a perspective from the work that we're doing on tackling anti-racism. But I think certainly there's a wider conversation here, isn't there, around deprivation and access and the health of women through their pregnancy, but also beyond pregnancy, particularly in the first year of life of their child.
Sure.
And so I think I gave some detailed description of the inequalities element of SK6 tests, and in the consultation in North Central London, that will be one of the key tests we'll be applying in that process.
Okay, sure. I might take that up separately with you, just to highlight a few of the concerns I have on that particular issue, because that's not for this committee as such. But just on moving on to HEY, Healthy Early Years London. So just an open question really, and Jazz, you might be the best to answer this one, in terms of the progress that has been made on the refresh of the Healthy Early Years London programme, and how does this tie in with regional efforts to tackle child health inequalities?
So the refresh is very much about trying to update both the Healthy Early Years programme but also the Healthy Schools London programme. Since both those programmes were established, other parameters have changed. So the government has introduced, as part of its Ofsted rating, a health and wellbeing sections to their Ofsted rating. So first task is to update based on those and make sure the Healthy Schools London and Healthy Early Years programmes enable those settings to be able to provide the evidence they need to meet those areas of work. Some of the particular areas of work have also been about trying to make sure that there is more consistency in the way those programmes are being delivered and that they are supporting those settings. I think it's also recognising that the backdrop of this, the early years sector has suffered a significant challenge, both in terms of its market's kind of viability. Those are real challenges, but also recognising now with the wider conversations around the early years sector and access to free childcare, for example, it's putting huge amounts of pressure on that sector. So the way in which we're supporting them right now, whilst we're looking at a long-term agenda to really set these programmes into the future and make sure we're future-proofing what these programmes could be doing, it's also doing that in the backdrop where there's a lot of tension in that sector.
And just to be clear, you're referring to the changes that are proposed in terms of the younger children are obviously being brought into earlier settings.
Yeah.
Okay. Yeah. Good. So just in terms of again on Healthy Early Years, how is the refresh programme factoring the mental health of pregnant women and birthing people, new mothers and parents?
Yeah, so that's actually one of the key elements of the change. We want to really strengthen the mental health offer in those, both in terms of supporting staff to have better confidence and understanding of both how they're supporting the well-being and wellness of the children that they're looking after, but also recognising that their community, their wider kind of family that they're part of, includes those parents. And often these are families, they're working with families who are often in those stages where people are having babies and mums are having babies. So actually they have access to a much richer community of new mums. The opportunities there then, so we're exploring what those opportunities are, how we can strengthen mental health, but also make that offer beyond the relationship with the child, but actually making that much broader.
Okay. And do you still do the annual Hay Awards at City Hall, or not anymore?
No, we don't do those at City Hall. I think because of the pandemic, we kind of that went away. But also, but we are seeing a continued increase in the numbers of settings taking up and wanting to be part of the HALE programme. Okay. We are seeing, so we've seen the Bronze Award continue on that trajectory of growth, and we're now beginning to see an uplift in people moving up to silver as well. So, which is really encouraging.
Okay, thank you.
Thank you. We're going to have a 5-minute recess now, and then we'll reconvene again at 4:05. And so Okay, thank you very much. We will now continue with the questioning, and I'm going to go over to my colleague, Assembly Member Russell, for the next question. Thank you.
Thank you, Chair. So in our, we're sort of cycling back to the beginning of this term of the Mayor, and we did a report on reducing drug deaths in London. So we've got a few questions to pick up on progress on reducing drug deaths in London. So my first question is about can you update the committee on the work of the London Drugs Commission since it was launched in May 2022? I don't know who wants to take that one.
I'll start, and Vicky will probably come in. So obviously it's been set up. It's going to probably report later in 2024. It's kind of very much kind of it's meant to be very much an independent commission, and the idea is it will make recommendations to improve our approach to tackling drug use, help tackling drug-related crime, and protect Londoners' health. It's very much got a public health approach, so therefore I was involved in making sure who are the kind of experts you want to bring to the table to give advice to the Commission, because there'll be public health experts who are focused on drug treatment and how do we make sure we improve our drug treatment services. And then there are mental health experts who deal with patients with serious enduring mental illness and the impact of recreational drugs on those patients. And so it's meant to be a real public health approach. So they're now taking evidence, and my understanding is the Drug Commission report will come out later this calendar year. Vicky?
So not an awful lot to add, other than we've had the opportunity to provide evidence and submit evidence. Virginia Berridge actually was one of my lecturers when I did my master's many years ago, so that was quite a nice reconnection to make. And just to say that the Association Directors of Public Health have also been involved in kind of evidence and making sure that it reflects their perspective. Mm-hmm.
So later in 2024, the last we heard about when the Drug Commission was going to report was, we were told in January 23, so over a year ago, we were told it would report in autumn 2023. So it does feel like it's very delayed, and we still have quite a vague time frame for publication. So later in 2024 could be any time up until December 2024. Are you able to be any more precise about that?
I'm not. It's because of the level of independence that this commission has. They're taking their evidence in a way which suits what they understand as the best approach in developing the work of this commission, and all I've been informed is they're still taking evidence, they're still considering evidence from the UK and internationally, and they're still and it will take a bit longer, and that is what I know. Mm-hmm. And I can imagine the frustration where it has been delayed, but I think it's getting the job done well rather than quickly.
Very frustrating, but absolutely getting a good job done is definitely the best way to go. Now there are questions coming up on a couple of other things, but there's two of the recommendations that we made in the report. One was about overdose prevention centres, and the other was about trialling drug checking services. Those are two things that could be, the Mayor could, without the Drugs Commission reporting, could be being worked on. And I just wondered whether you'd made any progress on advancing those recommendations that the committee made to you.
So the one I can talk a bit about is the drug checking service, mm-hmm. Because we had a presentation on that work at the London Drugs Forum, but the licensing of that is carried out by the Home Office, and they are not willing to extend any licensing to do that in London. My understanding is there has been work done in the rest of the UK, another part of the UK, I think it's Bristol.
Yeah.
And they're waiting for reports from there. But we did talk about that, and the Home Office steer was we're not giving out any more licensing to do that until we've got further information.
Okay, so that's sitting with the government. Let's hope the government get on with that. And in terms of overdose prevention centres, where people can who inject drugs can take them safely with, particularly, I'm thinking because of the increase in synthetic opioids, which is leading to an increase in overdose, the kind of need for overdose prevention centres is pretty acute. You're not trying to do anything on that at the moment.
I would imagine a similar thing. It's the Home Office needs to give the appropriate regulation to do that, but that isn't something that the London Drugs Forum has debated at present. And I understand, again, it requires collaboration with the Home Office, who at present, that isn't one of their priorities working with us.
Okay, it seems a shame because I think, the Dame Carol Black report was all about prevention and harm reduction. But anyway, I'll hand back to you, Chair.
Thank you. Assembly Member Best.
Thank you. I'll try not to delve into drug checking because I think my colleague is going to pick up on some of those points, but interesting feedback. I wanted to go back to the London Drugs Commission. And Tom, you were talking about the fact it's independent and so perhaps not close to work. But who is receiving updates on this? Who knows what's going on?
So I'm not able to answer that. I'm not aware of that regular feedback system. Obviously I've asked in advance of this meeting, and the information I received was later in 2024, and all I can say I'm aware of when it was set up, having significant inputs into how we collect evidence, but then by the nature of having an independent chair, you very much pass on that kind of operational processes to them. So
but if we commissioned some work, it's a commission working for us, we'd expect regular updates and to know what they're doing. So who does that lay with?
So I know it was set up by MOPAC, so I can, if you wish, kind of approach MOPAC to see can I get a more detailed answer to that question. But it wasn't set up by the health team.
Okay, so perhaps if we can find out who in MOPAC, but I think we should know, at least in the health team, who is the GLA contact or the GLA family group contact for this work.
Vicky can answer.
Vicky,
yeah.
This is the health and policies approach.
Yeah, so within the unit, the lead is Farah Hart in terms of community safety, and this would fall within her remit.
Okay, thank you. So if we were speaking to Farah would be getting regular updates on what the London Drugs Commission's doing and what point they're at with their work.
We would, as a unit, we would enable them in terms of contacting partners where they're looking to seek to collate evidence, etc. We wouldn't be getting a readout from the work of the Commission.
I'm sure you want to know where they are at certain points. So, for example, the key date for me is the consultation end on the 7th of July 2023. Do you know how many survey responses we got back from that?
Not off the top of my head, no, but I can find out.
Okay. Because that's one of the key pieces of evidence. If we got 20,000 responses, then perhaps the delay that we spoke about earlier might make sense. If there was 15, then that would seem like perhaps there's some other issues around there. So this is a really big piece of work, and it's just been delayed, and it seems like there's little kind of feedback on what's going on or ownership that we want this to happen, and we want to know where it is or what the progress is.
So we will go to MOPAC, find out the information that you've asked, and feed that back to you. I think that's as best as we can do, because it is led by another team. We have been involved in the setting up of the service and the Commission by making sure we give the appropriate advice. Health and Policies is live by one of our public health consultants being the key link, but the detail of the regular feedbacks and updates we don't have, but we can definitely get that for you.
Okay, thank you. And how much has been spent on the commissioning and work thus far of the London Drugs Commission?
We'll need to come back to you with that information, with the other information. So you want the lead officer within MOPAC, and you want to know from MOPAC how much has been spent on that commission.
Yeah, I think it's something that, to me, I'd really want the public health team to be all over. So hopefully that can be taken back. Turning to the Reducing Drug Deaths in London report, the Mayor said at the time that allowing more settings and individuals to provide take-home naloxone would enable local areas and organisations to be more flexible and responsive to those local needs, so largely supportive of the committee's recommendation around expanding naloxone. Can you provide an update on the work on that?
At the moment, we're working with the naloxone prescribing in a number of areas. So, as you're aware, naloxone used to be done by an injectable form. Now it's done by a nasal delivery system as well, which makes it more easy for people to deliver. So, the London ambulance services cover all ambulances have naloxone on site on their ambulances. A number of housing association projects which work with drug users have got their staff being trained to, and these are often projects funded by the GLA, the staff trained to give out naloxone, to identify the overdose, to administer it and to call appropriate help, etc. The third area that we're debating at the moment is with the Metropolitan Police Service to see would the Metropolitan Police Service consider giving their officers a naloxone. At the moment, the custody suites have naloxone. So if a person is brought into custody and has a possible opiate overdose, they will then issue naloxone. But the officers on the beat at the moment do not carry naloxone. We've asked them to look at it, and in fact, we had a discussion earlier today, and it is still under active consideration. Because London is so well served for emergency services, the police are very rarely in London the first responder to an opiate overdose. I'm giving you the rationale from the Met Police. Secondly, the number of times that the opiate overdose is actually part of the reason when they attend someone who down has collapsed is quite minuscule. The cost of training and issuing naloxone to all officers is about £800,000, and so at the moment it's not considered an operational priority for the police accordingly, and they will take it. It's always under active consideration. We've had a discussion with the Met Police a number of times. They're very engaged in this process. They've also got a lot of training to do, and they will prioritise their training, which produces the most benefit for Londoners. But that is their present position, which they have backed up by a lot of evidence, and will be regularly reviewed, in the future.
So I wanted to pick up on a couple of points there. So going back to some of those schemes that are being rolled out around housing associations. What's the scale that we're talking with that?
I can get you the figures, but I know a significant number of hostels do have facilities to administer naloxone, but I can get you the I don't have the figures, but I know of examples.
So is it examples of almost pilots, or are we talking tens or?
No. It's established practice. They're not pilots.
Okay. And so coming back to if you could get some more definitive numbers.
We'll do. Thank you.
Thanks. And coming back to the point around the Met as well, you've had these long drawn out discussions where we've backed up evidence on where they're the first responders. is that evidence as well that we could see as a committee?
I can ask if that can be shared. Yes, it's a paper that the Met Police produce. Which it wasn't one that we produced, so therefore I would have to ask them if they are willing to share it.
Yeah, because I'm just trying to think, when you're talking about minuscule numbers, I mean, if it's even free in a year, £800,000 to save 3 lives is probably worth it in my book.
Yeah, so I'll ask them to get the data, but yeah, we did have a regular reviews on this issue.
Okay, thank you.
Thank you. Assemblymember Boff.
If we can just roll back to the answer you gave to my colleague about the Home Office issuing licences. When did you meet with the Home Office?
So we had it's September 23, I think it was, the London Drugs Forum discussed this, and we had a discussion whereby the Home Office position was described to us at that meeting.
Right. Well, that explains a bit. Would it surprise you to know that by September, another major city in the United Kingdom is going to be having a drugs testing service?
That's September 24.
24.
Yeah.
And by the end of this year, there will be other cities as well having drugs testing services. Why is London holding back? Why are we being laggards?
No, all I can say is that this is the advice we were given at the London Drugs Forum meeting, and that was advice at the time. I mean, you're giving me information now which is new to me, and so we'll take that information and revisit it.
Please. As you know, the Assembly passed a motion to recommend the setting up of these units because we happen to think they're extremely important for the health, especially of young Londoners. Yeah. And I would hope that we can be in the driving seat for this, rather than just waiting around for other cities to get there first. Thank you. I'll move on to my next question, which I've got to read first. The Mayor's response to excuse me. The Mayor's response to the committee with regard to reducing drug deaths in London stated that there may be a role here for the new London Drugs Forum to share good practice for effective communication campaigns between boroughs. What's happening now between boroughs, and have you been at the centre of that communication?
Therefore, so the government set up a new grouping called Combating Drug Partnerships, which in London are all borough-based, essentially. 3 of them are 2 borough-based. So they're the ones given the responsibility and the funding to address the issue of drug harm in London. So what we then did was to try to do a convening role, and so about 6 weeks ago we convened all the CDPs, SROs, to come together, actually at City Hall, to do 2 or 3 things. The number one is of sharing practice. What do you do in, kind of Wandsworth, which can also be done, in Ealing, etc. Number 2, what are the things which need to be done once for London, and what are the things which maybe need to be done in larger groupings of CDPs? And South East London were in fact a very good example. So they've set up a South East London group. What they recognise, the good examples is, let's say, prisons. So people leave prisons with a drug issue and they need to go to a service. Now, the service might well be, so the prison might well be in one borough, but the person lives in another borough, and so therefore
silos.
Indeed. So therefore, we are now combating those silos by bringing these CDPs together. And also the issue, let's say, regarding training and workforce, because what you don't want to do is try to steal worker from borough A to come work in borough B, and really you're not really increasing the numbers of workers in the field.
I don't want to cut you off too far, but I'm very conscious of the time.
So we are doing that work that you suggested, yes.
It is happening,
yes,
it's active. When was the last event?
I think it was January this year.
Lovely, thank you so much. I'll hand back to the Chair.
Great, thank you. We're moving on to the next section, which is on trans and gender diverse Londoners section, and Assembly Member Russell will take over on that.
Thank you, Chair. Yes, so this section is about the response to the report that we did, Trans Health Matters, Improving Access to Healthcare for Trans and Gender Diverse Londoners. So that's, again, it's a report back from the first term, the first year of this Assembly term. And one of our recommendations was about using the principles of the Health Inequalities Strategy. The Mayor should convene a consultative group comprised of Londoners with lived experience and subject experts to look at the implications in terms of health inequalities for trans and gender diverse people's healthcare and using their insight to drive improvements in provision with partner organisations. So my question is, sort of in the Mayor's response to the report, the Mayor said that he engages with trans stakeholders through the Equality, Diversity and Inclusion Advisory Group, and that includes specific expertise on trans issues, including relating to health. So I'm just wondering if we can have a bit of an update on that work, and has the Mayor undertaken any further work with this group to explore trans and gender diverse Londoners' experiences of healthcare?
So if I start and colleagues might come in. And I think the Mayor was very clear that having this group, which already has specific expertise on trans issues, rather than setting up another group, he wanted to use that group and bring your report to that group, which he definitely did. That group is chaired by Debbie Weeks-Bernard, who is a Deputy Mayor for Communities and Social Justice, and I understand they wrote back to the Health Committee in October 22, explaining their involvement thereafter.
I think I was asking for an a sort of more recent update.
And subsequent to that, Sadiq then wrote to, I think, Simon Bolton, who was the Chief Exec of NHS Digital, because it's an NHS national issue about can we have on the data of all healthcare records the trans status of a patient. They've said they're working on that, but it's got to be a national solution. And then also the Sadiq kind of it tries to kind of identify that regarding trans health issues, because we don't commission health services, but all we can do is advocate and spotlight, and that's what he wants to do in this area. And I think his work with Debbie Weeks-Bernard is the area where he wishes to use that committee to do that focusing, to do that spotlighting and advocating. Anybody, colleagues, want to add anything more? Jazz?
Just briefly, just to add, I suppose, is there's a wider conversation about EDI more broadly. So the EDI Action Group is, so we've had at least 2 or 3 sessions with the EDI Action Group that talk more broadly about EDI challenges within the health and care system, and trans and wider LGBTQ issues have come up as part of that. But it's in that wider context. How do we work with the NHS to work with what they want to do? There is an appetite within the NHS to really tackle the various aspects of discrimination, and this is one of them. So there is an open conversation. The NHS are part of that wider open conversation that Debbie's grown.
I think it would be really good if there could be a bit more focus on that. I mean, one of our recommendations was very specifically that NHS Digital should improve NHS IT systems so that all healthcare providers are able to record trans status in a consistent and inclusive way. One of the things we heard very strong evidence from the panel that came before us when we did the report that GP systems just don't allow for trans status or gender diverse status to be recorded in a consistent way. The only way you can do it, some GPs had a kind of workaround where they kind of had a warning flag that came up, but you don't want a warning flag that someone is trans. You want that to just be part of the data that the NHS is collecting. And I think, what we had hoped with our recommendation was that there would be real advocacy from the public health part of the GLA to really try and push forward with this. So I think, is that something that you can take forward?
So we tried, the NHS Digital answer was that because you can't do it just for London, It's because the GP records are electronic and they move from London, and the next day the person might move to Bristol. So they've said this can only be done as a national approach. They've heard what we've said on behalf of the Health Committee. We've done it very clearly, and they will look at it in a national policy, but they would not recommend that London goes alone in it, because that would break the idea of the National Health Service's digital IT health record.
Of course, it needs to be a national thing, but I mean, I suppose the hope is that each of you, in any kind of opportunity you have, will take the chance to advocate for a more inclusive record-keeping process for the NHS.
As that what you were saying about you having a workaround. I mean, as a GP, we try to make sure we can identify in a appropriate way our trans patients, but you want to do it whereby it doesn't just come as a flash of an image up on the screen, which is the way you often can do GP alerts, which is, as you say, highly inappropriate.
Now, the Mayor also said that he will encourage the London Health and Care Leaders Group to discuss the recommendations from our report and ask them to use their influence to promote our recommendations with wider NHS and OHID colleagues. Now, for instance, we had all sorts of just sort of practical things about commissioning trans-inclusive training programs for primary care services, things like Pride in Practice, things like encouraging support and non-clinical staff to understand how to provide a trans and gender diverse inclusive environment, encouraging practices to review their policies to make sure that they're trans and gender diverse friendly, and reviewing surgeries to ensure that they are trans friendly, including by, for instance, displaying LGBT plus posters and leaflets. So I just wondered, is there any work going on in that sort of space, that kind of advocacy communications piece, where the Mayor could be using his kind of convening powers and his voice of persuasion around health inequalities to speak up for trans and gender diverse Londoners and the healthcare experience they have in London?
So first of all, we have raised it with our NHS leaders, and I can just talk from a personal perspective that the Pride in Practice initiative has been now much more widely advertised amongst the GP community. The trans training offered to general practice is, it didn't exist 10 years ago, and we've had training sessions at our practice for trans identity and healthcare issues. So that definitely is happening. We raised it with the NHS, and just from a GP practitioner's end, I am seeing the fruits of potentially your work and the work of other allies in this field, whereby those outcomes are being achieved.
Thank you. I'll leave you with that as something to just, that's an ongoing request from us as a committee. I've just got one final thing, which is that we saw a government announcement yesterday about banning the provision of puberty blockers to children who are trans. And I just wondered if anyone had anything they wanted to contribute on that as a reaction to that. I don't know, Kevin, if there's anything you are able to say.
Unfortunately, no. It's not in our area of responsibility in OHID in London. Thanks.
Thank you. I'll leave it there, Chair.
Yes.
I noticed the wording of that press release from the government. It says routine. Routine issuing of puberty blockers. Well, they were never issued routinely anyway, so it still opens the door for them to be allocated to those children who need it.
I certainly know that the first centre for dealing with children with transgender issues was going to be open in London. It's been delayed by 1 year because 4 of the consultants resigned, right, because they couldn't come to an agreement for how the service should be provided. And so this is an area of great debate in London, certainly, and I'm sure we'll keep an eye on that. Are we all? No? We're all done. We're all done? Okay. Look, thank you very much to our guests for all your contribution today to the committee. Can we please note the report and today's discussion? Can we also delegate authority to me as chair in consultation with party group lead members to agree any output from the discussions? Okay. The date of the next meeting of the committee will be confirmed at the London Assembly's annual meeting in May 2024. As this is our last Health Committee meeting of the Assembly and this mayoral term, can I please thank all my committee members for your support, for your hard work, and for your commitment to improving the health of Londoners. And was there a hand up for something?
It's only because everybody got off so early by thanking you so early in the committee meeting, and I thought, well, that just makes it longer, doesn't it? But I'd like to record my thanks. I've served with you, Onka, for a very long time now, and apart from the fact that you are an expert in your field, it's always useful to have a GP at hand when I've got aches and pains, and you've always been very helpful in that respect. But your knowledge of health has been unmatched by anybody, and your service to the committee is truly appreciated. So thank you very much for the time that for your chairing skills. Thank you.
Thank you, Andrew, and for Vicky.
Apologies for protracting it slightly longer. Also to offer thanks and best wishes from Professor Fenton and myself. I've worked with you for the past 2 kind of administrations, and just acknowledging all the contributions. Thank you.
Thank you.
Thank you very much. I'm really humbled by this, and those temporary patient resident forms of files which were made at the Health Committee, made at the London Assembly, will be confidential. so don't worry. Okay. So may I thank you all once again for your support and all the guests. And there's no urgent business, so I'll call this meeting to an end. Thank you.
Well done.
Thank you.
This is the broadcast